The Oncotype DX can be used as a prognostic indicator in node-negative women. This is important because, by and large, node-negative women do well, but some don't. So who are the women who are not going to do well? It would be nice to know at the beginning, because your intervention is most powerful at the beginning of therapy. You can predict response to various forms of chemotherapy using this panel, and you can actually get quantitative data on your receptor status. It turns out that some of the testing that's done sort of in the labs in the general pathology departments are not as accurate as you would like them to be. And so this is a more accurate assessment. And it appears that Oncotype can actually begin to be used as a prognostic indicator even in node-positive patients. We have such an array now of chemotherapeutic agents that we can use. It's really, the recipe index is broad. So it's helpful even in node-positive patients to have this information. A low recurrence score would indicate that the patient has a minimal chance of having a recurrence and would likely not benefit from chemotherapy. This is helpful because you don't want to give 100% of women chemotherapy when only 2 or 3 of them are going to benefit. It's a lot of money, it's a lot of grief and aggravation. And those patients who have a high recurrence score clearly will benefit from chemotherapy, so you want to give it to them. The data for the validity of Oncotype DX was generated from 12 studies of more than 4,000 patients. So there's good convergence of data for this. And I believe last week Oncotype came out with a similar panel applicable to colon cancer. The clinical utility of Oncotype DX relates to the fact that there are 110,000 women this year who are going to be node negative and ER positive. Typically older postmenopausal women, mostly whose breast cancers are discovered by mammographic screening. This represents half of all the new patients diagnosed in the United States today. And so the question is, should these women receive chemotherapy? Because there's a lot of data that shows that women who receive chemotherapy do better, but not everybody. So who will benefit and who will not? That's the question. So here's a patient that I used it on myself. She's 55 years old at the time of diagnosis, which was 2 years ago. She had a family history of breast cancer. I've been following her for 11 years, so I was seeing her as a high-risk patient every 3 months in my practice. Her mother had had breast cancer at 47 and died of disease. Her grandmother had breast cancer at the age of 70. She was BRCA negative. She's got another gene. I don't know what it is, but she's BRCA negative. She'd been smoking 1 pack of cigarettes a day since the age of 15. Why is that important? It does. Yeah, I don't know that there's a hormonal relationship, that there might be, but there's definitely a direct relationship between cigarette smoking and breast cancer. And it's dose dependent, and the earlier the woman is when she starts smoking, the more her risk is. So these teenage girls who are smoking at the age of 15 and then they stop at 25, they have a risk, an increased risk for breast cancer. She's never used oral contraceptives or hormone replacement therapy. Why is that important? Yes. And oral contraceptives are carcinogenic or not? Yes. Are you ladies aware that in 2005 the World Health Organization classified oral contraceptives as a group 1 carcinogen? Highly carcinogenic, on the order of lead and benzene, known to cause cancer in humans, 2005. If you go to the package insert for birth control pills, the FDA does not say that. No, they say it's not clear whether this increased risk of breast cancer, which persists for 10 years, as if that were nothing, it's not clear that it's related to the pill. Well, the World Health Organization reviewed the world's literature. It was a huge committee, and they say yes. She does not drink alcohol. Alcohol is a risk factor for breast cancer, and that is hormonally related. While your liver is metabolizing alcohol, it cannot at the same time be metabolizing estrogen, even the little bit of estrogen that you're making in your fat or in your adrenal glands. And of course, if you have a little something to drink every day, which is what the conventional wisdom is, have a glass of wine a day or whatever, so you have this sort of chronically elevated level of alcohol in your blood, and a chronically elevated level of estrogen as a result. So there's a direct correlation. Now, early on, we thought, oh, only if you had more than 2 drinks a day. So, of course, I was happy. I was off the hook, right? Then it turns out, about 3 years ago, half a glass of wine a day. Very sad. Very sad day for me. Yeah. Okay, so her first full-term delivery was at age 30, and we know that 2 pregnancies before the age of 20 is very protective. After the age of 20, you really don't get the benefit from pregnancy. If you have a late pregnancy after the age of 30, particularly after the age of 35, you increase your risk of breast cancer for probably 2 to 3 years. She had her annual screening mammogram, and she was found to have a mammographic abnormality. She had a stereo biopsy, and she was found to have a 6-millimeter, well-differentiated invasive ductal carcinoma. Well, of course, she sort of went berserk, and she wanted both breasts removed, and wanted everything to be done. She had a partial mastectomy with negative margins. We did a sentinel lymph node biopsy. It was negative by H&E and by immunohistochemistry. So she had a very small cancer, very low grade. It was ER positive, PR positive, and HER2 negative. So it was a luminal type A, a very good actor. She should do well just with Arimidex, right? Very well. She had no lymphovascular invasion, and she had no metastatic disease. She had lumpectomy with radiation therapy. We sent her tissue off for Oncotype testing, and she came back with a recurrence score of 10, which translates as a very low risk of recurrence at 10 years, about 7%. The range is 4 to 9%. So the decision was not to give her chemotherapy. Tiny tumor, sensitive to Arimidex, complete negative margins, and no chemotherapy. It seems reasonable. So Oncotype really helped her. I think when she saw all of that, she felt better. This is an array of the genes and the proteins that have crossed my radar screen just in the past 6 weeks. So it's a huge, very busy field. Huge frontier, lots of places to go. Everybody seems to be headed off in a different direction, sort of like, the land rush. What was it in Oklahoma where it was, where you could get 1,000 acres and a cow or something? Yeah. I'm headed off in one particular direction, and that is in search of the pink virus. So part 1 was really just to set the stage, to understand the genetics and gene expression and the validity of that and the importance of that. And now I want to talk to you about the pink virus